We did part one of AKI a few days back, and today's part would be a rehash of the same, probably pertaining to the important questions which you may be, getting in the exams pertaining to ED. So I'll just try to put it in certain case vignettes and try to make you understand that. So this was the case vignette. You had a 72-year-old woman with a history of hypertension and heart failure who presents to the emergency department with fatigue, giddiness, and decreased urine output for 2 days. Now she had an episode of viral gastroenteritis with multiple episodes of diarrhea and poor oral intake. So we did a physical exam and the findings were as follows. BP of 95 by 60, heart rate of 110 beats per minute, dry mucous membranes, decreased skin turgor, and no peripheral edema. Labs were BUN of 45, creatinine of 2.1, urine sodium was increased, 10 milliequivalent per liter. FeNA, or the fractional excretion of sodium, was 0.5%. Urine analysis did not show any protein or any casts. So the diagnosis is fairly straightforward. It's a pre-renal AKI. Now, what we need to know in this, or what may be asked out of this, are the diagnostic and definition cutoffs. Now, we've done all the three criteria, rifle, Akeen, as well as the KDIGO criteria. Now, in the past class, and the KDIGO criteria is the one which is supposed to be the most valid. In the past class, I also covered that we need to know about when to intervene in oliguria, how is it important, and about the prognosis of an oliguric patient, stating very clearly that whether a patient, if he or she is oliguric, whether they have a better prognosis, when are they expected to open up, and accordingly. We also need to do a prognostication between oliguric vis-a-vis non-oliguric subsets. Then you have certain scoring systems for AKI. Again, the same thing. So how do you intend to use them and how do you intend to move forward in them? And also be able to elucidate the broad principles of treatment. Now, what are the broad principles of treatment? Is there any doubt? Okay. So basically, most of the times the broad principles of treatment would be hydration. Hydration would be appropriate hydration. When we did it in the class, it was very clear that when we talk about appropriate hydration, volume overload is also detrimental. And actually, this gives rise to bad outcomes. So an appropriate volume resuscitation, maintaining a good pressure head, and thirdly, of course, avoidance of nephrotoxic medications. So whenever we talk in terms of AKI management, the broad principles of treatment would remain the same. There's the second vignette. You have a 60-year-old man, type 2 diabetes and hypertension, who is admitted to the ICU with septic shock because of pneumonia. Now, this guy was started on broad spectrum antibiotics and he required vasopressor support. Examination findings, BP of 80 by 50 mm of mercury, tachycardic, heart rate of 115 beats per minute, cool extremities, as well as decreased urine output or oliguria. So when we go through the labs for this particular patient, BUN of 50 milligram per deciliter, creatinine of 3.4, baseline was 1.1 milligram per deciliter. Urine sodium was increased to the tune of 50 milliequivalent per liter. FeNA, or the fractional excretion of sodium, was increased to the tune of 3%. Urine analysis showed muddy brown casts. So quite clear, it is most likely a septic ATN or probably acute tubular necrosis secondary to sepsis. So this is basically the intrinsic AKI or the renal type of AKI. So now here we need to know about the potential pitfalls of serum creatinine values. They were discussed earlier in the earlier class. And we need to know when to use our serum creatinine values, what are the caveats, what are the true and false values, and how you need to interpret it with caution. Plus, serum creatinine levels will never give you a timeline of the renal insult, so that also needs to be ascertained and that also needs to be emphasized. We need to know the timelines for cortical necrosis, when it is bound to happen, and when you would get a cortical necrosis, especially on imaging. We also need to know what are the current concepts in terms of avoiding volume loading, identifying new means of fluid resuscitation endpoints. Now, I'm not too emphasizing too much on that because there would be a hemodynamic monitoring module in which you would cover it about how you would actually be doing the newer modes or the newer means of what would be your fluid resuscitation endpoints and how would you actually assess volume responsiveness in current context. Of course, another one would be choice of IV fluids, which you would use, where you would use normal saline, where you would use ringer lactate, which we covered, and where all would you use balanced fluids if feasible. Then what is the value of urinary sediment? Of course, when you would see a clear sediment, when you would see a muddy brown sediment, or when you would see certain other things and how important are they? So this is all that needs to be covered. And of course, urinary sodium and fractional excretion of urea. Why it becomes important is because certain of these patients may be having, lactic acidosis, or these patients may be on diuretics. So in these patients, FENA may not be that accurate. And in those patients, you have to talk about fractional excretion of urea. So these would be the discussion points for a intrinsic AKI. So when it comes to differentiation, this is a broad one, but basically just to remember, I put a slide. We've discussed it in the main class of acute kidney injury. So this is pre-renal, wherein you had dehydration, heart failure, also known as cardiorenal syndrome, liver failure, also known as hepatorenal syndrome. Of course, intrarenal causes, namely intrinsic renovascular disease in the form of hypertensive emergency, small vessel vasculitis, thrombotic thrombocytopenic purpura or hemolytic uremic syndrome, then glomerular disease in the form of post-infectious glomerulonephritis, then tubular interstitial disease in the form of acute tubular necrosis and acute interstitial nephritis. This acute tubular necrosis would be mainly seen in sepsis. Sepsis is the most common cause when it comes to ICU. And all of the other things, medications, some certain nephrotoxic medications, then contrast-induced injuries, if any, rhabdomyolysis, or maybe a prolonged pre-renal AKI, which has actually progressed onto intrarenal AKI. Post-renal causes, obstruction, mechanical obstruction. So either it would be a ureteral obstruction, neurogenic bladder, then there can be a urinary tract infection because of retention of urine. Then there may be certain medications in terms of certain irrigations that are used. And of course, benign prostatic hypertrophy. Little word about NGAL, we need to know. It's a biomarker and it can be positive in AKI, chronic kidney disease, patients of stroke. These are false positives, heart failure along with CKD. You need to know the measurement specifics, how much time it takes, and when do you expect it to be of value to you. Most of the times, it is a cardiac surgery specific scoring, wherein the cardiac surgery subsets are the one which actually benefit most by using NGAL. We discussed this before last time, and we need to know the biomarkers in that context. This is the cardiac surgery associated acute kidney tubular damage, and this is the score at which you think in terms of tubular damage. Cardiac surgery associated NGAL score, that's what it's called as. So 0 is tubular damage, where it is unlikely. Then 1, you have a possible tubular damage. 2, you have a tubular damage. And third is, of course, a severe tubular damage.